Hi, everyone. I'm Rachael Grace. I'm a pediatric hematologist and clinical researcher at Boston Children's Hospital. And I've been asked today to give a brief overview about pyruvate kinase deficiency, which we'll call Pyruvate Kinase Deficiency 101. Before I get started, I wanted to let you know about research disclosures that I receive research funding through my hospital from both Rocket Pharmaceuticals and from Agios Pharmaceuticals, which both are working on clinical research in pyruvate kinase deficiency. I also wanted to just take my video away before we get started so that you can see my slides a bit better. Before we talk about pyruvate kinase deficiency, let's talk first about how healthy red blood cells can make energy. Healthy red cells last approximately 120 days or 3 months. And red cells do this even though they don't have a nucleus or an organelle called mitochondria like most cells have. Instead, red cells rely on a process called glycolysis for their energy, which is in the form of ATP. Glycolysis is the process where glucose or sugar is converted into energy or ATP. And you can see in the simplified diagram that the body uses pyruvate kinase as an enzyme in one of the final conversion steps of glycolysis to make energy. When there's a deficiency of pyruvate kinase, there's not enough conversion of glucose into energy. And you can see this again in the simplified diagram. When there is a deficiency in pyruvate kinase and there's not enough ATP or energy for the red cell, it can't maintain its outer membrane shape or the outer shell of the red cell. It also can't maintain all of the electrolytes coming in and out of the red cell. And for those reasons and others, the red cell breaks apart earlier. And so instead of lasting 120 days, the red cell lasts only days or weeks. When the red blood cells hemolyze or break apart earlier, there are a number of laboratory manifestations that are listed here on the left side of your screen. When there's a breakdown early of red blood cells, there tends to be anemia that's associated with it. With this, we typically would see a low hemoglobin level, which is what most people use to describe anemia. In addition, we see an elevated bilirubin level, often elevated very mildly so in some people, lactate dehydrogenase or LDH levels. And in people, we also see low haptoglobin levels, a protein in the bloodstream that binds up to hemoglobin and is decreased. In addition, with the destruction of red cells, we see the body try to compensate for this by making more red blood cells. So we see more red cells being produced in the bone marrow, the factory for all the blood cells, and we see this in the form of increased reticulocytes, which are our youngest red blood cells. So we have a balance between red cell destruction or hemolysis and red cell production, where the body's trying to make up for the fact that the red cells are being broken down. And we have a state of compensation where the red cells are balanced. And this helps to define what somebody's baseline hemoglobin value it is, or what their baseline level of anemia is. And this can be quite variable between different people who have pyruvate kinase deficiency. The figure on the right just shows you what's happening in the body with red cells, particularly as they go into the organs of the body that have the smallest blood vessels, which is the spleen. So you can see irregularly shaped red cells entering the spleen, trying to get through these very small vessels called capillaries, where there's very little oxygen. And in this environment, the red cells shear apart and don't survive, particularly the youngest red cells, the reticulocytes. And this is why we see such a problem, particularly occurring in the spleen, but also in the liver and on other places too. What causes pyruvate kinase deficiency? Well, it's a genetic disorder, and it's what we call autosomal recessive. This means people generally inherit one variant in the gene affected by pyruvate kinase deficiency, or PKLR, and one variant from another parent in the PKLR gene. And this means that many patients, or most patients, are what are called compound heterozygotes in terms of their mutations. They have two different mutations, one inherited from each parent. Some people are what are called homozygous for their mutations, where they have the same gene variant from each parent. There are many described variants with over 300 mutations described. The majority are what are called missense mutations. These are mutations that make one amino acid change, it's called, in the proteins, the protein that's being made. And these tend to be more mild mutations than those that are called non-missense, which are shown here and tend to be more dramatic in terms of their effect on the gene and protein production. These can be large pieces of the gene that are missing. These can be changes in the way that the gene is read, so it's only read in a short frame, or it's abruptly stopped. And these can lead sometimes to bigger protein changes. Most of these gene mutations are rare, and up to 20% of people who have genetic testing right now and have pyruvate kinase deficiency are found to have new variants that have never been described before in terms of their genetic changes. How is the diagnosis of pyruvate kinase deficiency currently made? Well, it's through a number of different steps that clinicians will come to a diagnosis of pyruvate kinase deficiency. First, there's usually evidence of hemolytic anemia, what we were talking about earlier, red cell breakdown and increased red cell production. With these types of laboratory changes, most clinicians first will exclude the most common causes of hemolytic anemia, and as you know, pyruvate kinase deficiency is rare. When these have been excluded, then two different tests are done to make a diagnosis of pyruvate kinase deficiency. The first is to look at pyruvate kinase enzyme activity, a blood test, and this should be low in people who have pyruvate kinase deficiency. The problem is that this test is difficult to do and it may not be available to everybody. In addition, it's not possible to do this test if somebody's been transfused recently, because then it will measure the transfused cells' pyruvate kinase enzyme activity. It also is low oftentimes in people who are carriers of pyruvate kinase deficiency, like the parents of children who have pyruvate kinase deficiency. And so it is difficult to distinguish between a carrier and somebody who has two variants. In addition, sometimes we need to get other enzyme levels, other red cell enzyme levels, in order to interpret the pyruvate kinase level. Because of the challenges in the enzyme level, we use a partnering test of genetic testing where the PKLR gene is sequenced as part of our diagnostic approach. And this too is a blood test. This can also be challenging because there's such a high rate right now, as I just mentioned, in newly described mutations and knowing whether these are disease causing or not. It also can be expensive, and in the United States may be prohibitive for people whose insurance won't cover the testing. And so there can be diagnostic challenges for sure in coming to the answer that somebody has pyruvate kinase deficiency. How common is pyruvate kinase deficiency? This is a very difficult question to answer and one that hasn't been studied rigorously. The prevalence of disease, of clinical disease, where somebody has manifestations where we see patients in clinic, is probably on the order of about 3 per million. There are definitely higher frequencies seen in certain populations, and we see that with the founder effect more commonly. That's where a group of people share common ancestry. We see it occasionally in patients where there's interrelatedness between family members, and then we see it too in areas where there's selective pressure, where it's beneficial, for example, to be a carrier of pyruvate kinase deficiency, like we see in other hemolytic anemias, and that's in malaria endemic areas. And those are highlighted in the figure here in yellow and orange. However, if we look at genetic studies, there's an estimated prevalence of pyruvate kinase deficiency of about 50 per million, which is much higher than the 3 per million we see in clinical practice. And it's really not clear why there's this discrepancy between what we think we would expect and what we actually see. And it may be because it's difficult to recognize pyruvate kinase deficiency, that perhaps some people have a different hemolytic anemia diagnosis, even though that's not really what they have. Could be because the diagnostic testing is challenging. It could be that people have mild anemia and so it's under-recognized, but it's really not clear why there's a difference between what we expect and what we actually see. What are the signs of pyruvate kinase deficiency in newborns? There is a wide spectrum of presentation we see in the newborn period, and I list here some of the different manifestations that we see, but it can range from no symptoms, no jaundice, no need for phototherapy, like is shown in this picture, to patients and children who present before they're born needing transfusions, or are born with heart failure and fluid overload because of anemia or liver failure or high ferritin levels as a marker of inflammation, and really can have extreme presentations in the newborn period. And this wide variability makes it hard for clinicians and neonatologists to recognize who to test for pyruvate kinase deficiency. And I think it's important to recognize this wide clinical spectrum, and really to have physicians to recognize the spectrum to be able to diagnose this condition in more people. The symptoms in children and adults can be quite variable too, as you all know. And for most people, there's anemia associated with pyruvate kinase deficiency, which comes with the low hemoglobin and the high bilirubin. And the low hemoglobin can be quite variable in terms of its impact on everybody's everyday life. Symptoms, as you know, could range from looking pale to being quite fatigued, and young children can be expressed as having a poor appetite with poor growth, sometimes indicating the need for transfusions. There can be poor focus in school or later on in life in work and in concentration. There can be difficulty with endurance and with exercise tolerance and participating activities outside of those necessities, like school and work. There can be episodic worsening of symptoms that happens with viral infections, with pregnancies, where there's increased hemolysis or red cell breakdown with those stressors. And then there can be a worsening of symptoms as somebody gets older, even though their hemoglobin hasn't changed for reasons that we don't quite understand. There can be quite a bit of jaundice and scleral icterus for people, particularly in certain people who have genetic variants where they are slower metabolizers of bilirubin, which is called Gilbert syndrome. And that can bring a lot of unwanted attention in childhood and teenage years and beyond in terms of why an individual might be a little bit jaundiced. There can be gallbladder disease and have symptoms associated with that. And then patients can have a large spleen related to red cell breakdown, which can lead to activity restrictions due to the risk of splenic rupture. This figure shows interviews that happened with adults with pyruvate kinase deficiency and how common different symptoms were reported from left to right. And you can see that jaundice came out as a major symptom reported, as well as tiredness, fatigue, low energy, shortness of breath, symptoms that are often associated with anemia. What are the complications we see of pyruvate kinase deficiency in children and adults? These too are quite variable between different individuals. There are some that are common and under-recognized. One is iron overload. So we see iron overload in people who receive transfusions always, and this always needs to be treated. But we also see iron overload in children and adults who have never been transfused or have only rarely been transfused. And so it's important for people to be monitored for this. Gallbladder disease is common, and we see this as a complication of red cell breakdown. And in addition, low bone density seems to be an issue in young adults and older adults with pyruvate kinase deficiency, and is under-recognized because it's only diagnosed with screening. In addition, there can be a number of other complications that happen more rarely, but can have a significant impact on someone's quality of life every day. And that includes pulmonary hypertension, high pressure around the lungs, endocrinopathies or hormone problems related to iron overload, extramedullary hematopoiesis, which are little pockets of tumors where blood cells are being developed, and leg ulcers, particularly in adults, which can be quite chronic. What are the current management strategies for pyruvate kinase deficiency? Well, I'm going to mention 3 here, the first of which is transfusions. So transfusions, as I mentioned, always come with iron overload. So I think of the management as being transfusions with chelation, which helps to get rid of the iron. Most people with pyruvate kinase deficiency are regularly transfused up until when they're splenectomized, and then intermittently transfused after that. When we look at registry studies, which is where this information comes from, we see that a significant portion is also intermittently transfused as needed for stressors and hemolytic triggers. Unfortunately, some people are regularly transfused, splenectomized, and then still regularly transfused after splenectomy. And then about 20% of patients have never been transfused. I just want to highlight, though, that even though somebody might have a low hemoglobin and the significant impact of anemia on everyday life in terms of symptoms, they may choose not to be transfused. So transfusion is sort of a difficult marker that we sometimes think of as a sign of severity of anemia or severity of illness, but really a lot of people have quite severe symptoms but choose not to be transfused because of all of the potential downsides, including with iron and needing access and the, having to go to the infusion suite and everything that goes with being transfused. In addition, splenectomy is a treatment for pyruvate kinase deficiency and happens in about 60% of people with this condition in our registry studies. The average age is about 5, and it increases the hemoglobin about 1.5 grams per deciliter. And we know when it's effective, it's only partially effective. People still have ongoing hemolysis and red cell breakdown. It comes with a number of potential risks, including the risk of blood clots of about 10%, the risk that it may not work, that you may still need transfusions afterwards of about 10%, and the risk of infection, including what can be serious infections with bacteria after splenectomy. It looks like when we assess predictors of likelihood of response to splenectomy, that perhaps having more mild anemia predicts a better response. Patients who have at least one missense mutation in their PKLR gene, have a higher baseline hemoglobin and a lower bilirubin before splenectomy are more likely to have a beneficial response. And then lastly, I'm going to mention stem cells transplant as an option that is curative for pyruvate kinase deficiency. This is where typically a sibling, a fully matched sibling, stem cells are used to replace somebody who has pyruvate kinase deficiency's own stem cells to abolish the pyruvate kinase deficiency. And this has not been conducted in very many people. So we have very limited data about what happens when people who have pyruvate kinase deficiency undergo transplant. This shows you data from one study that reported 16 people worldwide. And you can see that their follow-up was about 2.5 years. And there was a high rate of complications in this group. They were managed all very differently, which makes the data hard to interpret. But about 40% of them ended up with a problem called chronic graft versus host disease, where the stem cells and the body cells fight together, and it creates a new problem after transplant. And the 2-year survival overall was 75%, which also was low for pyruvate kinase deficiency. You can see in this graph, there's a difference between those who were transplanted younger than the age of 10 and older than the age of 10. So the age of transplant seems to make a very big difference in terms of the outcomes in transplant. But really not enough is known about this to know how best to advise people about whether this should be considered. And so most people will support patients with transfusions and consider splenectomy rather than going this approach. What types of monitoring might be needed in individuals with pyruvate kinase deficiency? So the list here is based on a number of hematologists' expert opinion, but not based on rigorous guidelines. Most people feel that people with pyruvate kinase deficiency should have regular blood count monitoring, reticulocyte counts, bilirubin, that there should be regular evaluation for iron overload or too much iron. That can happen at a young age, and that includes through blood tests or could be done through imaging through MRI studies. In addition, sometimes imaging is considered to assess for gallstones given the high rate in pyruvate kinase deficiency, especially before considering splenectomy. We also need to make sure to pay really close attention to care after splenectomy to make sure that all the immunizations are up to date, and those recommendations change every year, to consider prophylactic antibiotics, and to be sure that people understand fever guidelines, that fevers are an urgent problem for which you need blood work, including a blood culture and antibiotics, broad spectrum IV antibiotics right away. We recognize that bone density is an issue that can't be evaluated in the absence of a bone scan or a DEXA scan, that vitamin D levels are important to monitor. Certain populations may need testing for viruses, particularly the transfused population. that for people who have iron overload, that looking at an endocrine panel might be helpful. And then considering echocardiogram or ultrasounds of the heart for people who may be considering getting pregnant, who are after a certain age, 30 or 40, who are experiencing symptoms with concern for pulmonary hypertension, among other things. And we've thought about whether there are ways to categorize severity in pyruvate kinase deficiency. And this becomes particularly important when we think about new babies who are diagnosed with pyruvate kinase deficiency, and helping families think about what does the future hold. In addition, this could be helpful for thinking about monitoring which tests are most important in which people. And you can see here that we tried to look at this based on somebody's genotype category. Do they have two bigger mutations? Or do they have two of the missense mutations, or do they have a mix of the two? And you can see that the people who have two of the more dramatic or drastic variants are diagnosed at a younger age, have a lower hemoglobin, have gotten more transfusions, have more iron overload, are more likely to have a splenectomy. But we also see all of these same things in people who have two missense mutations. So really, although we know that if there's two non-missense mutations, it may be a bit of a more severe phenotype, we don't really know who to monitor based on this difference. And so I think this categorization can be helpful, but the monitoring guidelines probably need to be the same as far as we can tell for everyone with pyruvate kinase deficiency. What are our current research treatments that are being studied in pyruvate kinase deficiency? And that's one of the things that we're here to talk about today. One research treatment that's in clinical studies is our pyruvate kinase activators, and the one that's furthest along in trials is called mitapivat. And this is an oral medicine that activates pyruvate kinase, and it was studied in 52 adults with pyruvate kinase deficiency who are not regularly transfused. And in that population, 50% of patients had a hemoglobin increase of greater than 1 gram per deciliter. Phase 3 studies, both in transfused and non-transfused adults, are ongoing, but we still need long-term studies too in adults, and then it has never been studied in children, and these are needed as well. And there are other activators as well in development. And we're here today to talk about gene therapy as well for pyruvate kinase deficiency. And as others will talk about, this has been studied in animal models and mice, and now there's the first human study in pyruvate kinase deficiency open. And you can see the link here for more information about that. What are the unmet medical needs for people with pyruvate kinase deficiency? Well, you all could speak better to this than I could, but I certainly have been frustrated too by all of the areas that we need to know more and learn more. And really a big one is that we need evidence-based guidelines, they're called, for monitoring and supportive care. So rather than expert opinions, if we had evidence to support what we were recommending, that would be even better. And we can only do this with the evidence, with knowing what are the complications of pyruvate kinase deficiency, what are the monitoring that people have, and what are we seeing in people of all ages. And I would encourage you to consider, if you have pyruvate kinase deficiency, participating in research studies where we look at all these features through natural history studies or registries. And I put here in the pink circle the PEAK registry, which is a global effort to do this now and is ongoing. And feel free to reach out to me or go to the site if you're not participating and have interest. We also need reference centers for diagnosis. I was talking about how difficult the diagnosis can be, and we need ready access for all centers to be able to do this testing. We need networks available to people who may be only managing one person who have pyruvate kinase deficiency as a resource for advice about clinical care. And then we need disease-directed treatment. We need better treatment than the supportive treatment of transfusions and splenectomy and all of the potential complications that come with those. We need the disease-directed treatments to be available to people of all ages. We need it to decrease complications, improve quality of life. We need it to be safe, and we would want it to avoid splenectomy and transfusions. Where can you find more information about pyruvate kinase deficiency? I put some resources here, but it's certainly not all inclusive. One is the Voice of the Patient report, which is put together by the North America Rare Disease Organization with a meeting in the fall that many of you may have participated in. And the link is below to have access to this full report. There's also a small booklet available about pyruvate kinase deficiency for patients and their families. And the link for that is available to everybody is below too. And then there are lots of organizations and patient groups that have excellent resources for information and for connecting with other people who have pyruvate kinase deficiency. And I encourage you to do that. I thank you so much for your attention. I'm looking forward to the live event this coming Saturday. And please feel free to reach out to me if you have questions. And I encourage you all to consider participation in research and registry studies in particular, so that we could continue to learn more about pyruvate kinase deficiency and how to better take care of patients and their families. Thanks so much for your attention.